Hi, this is Elliot Fishman, and welcome to our latest series of talks. And this is going to be on the incidental adrenal mass, looking at some of the challenges, looking at some of the strategies, and how do we all manage these cases. It's something we've spoken about for literally 30 or 40 years, but there are changes going on, and I thought I'd share some of those with you. Now, the challenges in adrenal imaging are far more than saying, oh, look, there's an incidental adrenal lesion, which may occur in 10% of patients over age 50 or 60. We know most adrenal lesions are going to be benign, incidental, non-functioning adenomas, but not every lesion. Management decisions are critical, but biopsy is not recommended. We can do follow-up, but you want to follow up select cases, not every case. Imaging focuses on CT, but MR and nuclear medicine can be helpful in select cases. And again, we need to figure out, how do we triage patients? How do we know what's benign, leave alone, versus indeterminate, which may require further evaluation? At some point, a lesion might need to be resected perhaps, or what's going to be malignant. And then, of course, management will be determined based on the type of tumor that's present. 4 centimeters tends to be the magic number. It's the preferred size threshold for recommendations for managing incidental lesions. It used to be 3 centimeters, but now it's in the 4 centimeter threshold. So that works out fairly well. Size thresholds over 4 centimeters demonstrated less sensitivity than 4 centimeters, and size thresholds below 4 centimeters achieved higher sensitivity, but specificity values were significantly lower, and that's why 4 cm tends to be the magic number we all use today. The ACR currently recommends consideration of surgical resection for incidental adrenal lesions measuring over 4 centimeters without definite diagnostic benign features, with no prior history of cancer, and with no biochemical features of pheochromocytoma. Now, one of the things, of course, to remember with adrenal imaging, we look at the adrenal, we look at size, we look at density. We'll discuss that in a bit. But also we could look at biochemical features. We could look at epinephrine. Elevated epinephrine makes a diagnosis of pheochromocytoma, of course. European thresholds and guidelines tend to be different. They tend to spend more time on some of the functioning aspects and lab tests with incidental adrenal lesions than we do in the United States. I think in between is going to be the correct answer. In this article by Chung, they make a very good point that most lesions are indeed benign, but sometimes lesions are difficult, right? Adrenal adenomas is the most common benign lesion, while adrenal cortical carcinoma is a rare malignant tumor of the cortex. Cysts and myelolipomas are benign and have usually specific appearances. Pheochromocytoma may have hypertension, but it's usually very vascular. When you have METs, you usually have a known primary tumor. But when you get down to it, we have adrenal conference every other Friday, and you would think, based on all of the rules to date and all of our experiences, it would be very simple to make diagnoses. But I'm telling you that the overlap between benign and malignant lesions poses a diagnostic challenge, which we have to deal with literally on a weekly or biweekly basis. In that article by Chung, more recent data has shown that values are not as specific for adenoma as previously believed, since there is overlap with other tumors. Now, again, size of an adrenal lesion is one important feature. Again, we'll discuss a lot about a 4 centimeter range, but it's more than that. It's the heterogeneity. It's the clinical context. What else is going on? What physical findings? Is the patient cushingoid? Does the patient hypertension? All of those things go into making our diagnosis. And Chung makes the point it may be impossible to distinguish a large atypical adenoma from an ACC because of overlapping features. So again, we're going to have rules how things look, but I think it's very, very important to understand that the rules don't always work. A good point is multidisciplinary conference. That's what we have. Putting everybody together will often help you reach the most logical diagnosis, or surely the best diagnosis for that individual patient. Now, if we look at normal adrenal glands, they're varying shapes, but the limbs are typically thin. Adrenal glands do enhance normally up to about 60 or 70 Hounsfield units. When they're very bright, like this case, it means the patient is hypotensive. You'll often see other findings of hypotension, a flat IVC, which you see in this case. You may see marked enhancement of small bowel loops. You may see edema. You may see small celiac and SMA. But very bright adrenal glands are telling you the patient is hypotensive. There are many reasons the patient could be hypotensive, but it's an excellent warning sign. Hypovolemic shock was initially described in trauma patients, but it goes beyond trauma patients. On imaging, shock adrenal glands demonstrate marked enhancement with preserved content or contours. Persistent, intense adrenal enhancement may be a sign of shock that precedes other imaging features of hypoperfusion. So when I see that finding, it may be an ICU patient, it may be a patient we're examining for possible abscess, it may be a patient who has all sorts of varying symptoms. When I see the adrenal being very bright, I'll immediately call the physician and tell them that the patient is hypotensive, and this can be a serious condition. Obviously, it's a serious condition, but sometimes no one's sure why the patient's hypotensive. In this article, talking about septic shock and the hypoperfusion complex, bilateral adrenal hyperenhancement is the manifestation of adrenergic mechanisms that enhance the blood to vital organs. In arterial phase, the central zone of the adrenal shows less intense enhancement than the periphery, or presents as a mosaic appearance. In both cases, in the venous phase, the whole gland is homogeneously enhanced. Bottom line is you can make the diagnosis of really bright adrenal glands, be it arterial phase or be it venous phase. You could do it in both very successfully. Now, in terms of the adrenal, sometimes you see adrenals that look like this. Look, this is a patient with a brain tumor, glioblastoma. Look how small the adrenal glands are. When you look at them on the axial or you look at them in the coronal, they really do look really, really small. It's adrenal atrophy, and you can see that with a number of conditions. Brain tumors are one of them. The problem with adrenal atrophy, the patients can become Addisonian. So we talk about bright glands. We also talk about small glands. Sometimes when we see a unilateral adrenal mass, we'll look at the contralateral adrenal gland and see if it's atrophic, which may be due to hypersecretion of the contralateral gland. Now, of course, when we look at our referred patients or look at cases ourselves initially, if something looks like an adrenal mass, it usually is, but you can be fooled. Sometimes lesions off the stomach or pancreas or retroperitoneum can fool you. Here was a mass that was picked up on a chest CT. These were the lower scans, and you can imagine why somebody would say this is an adrenal lesion. But when you look at it more carefully, when you do the abdominal CT, you can see the lesions coming off the posterior gastric wall, and this was a GIST tumor. It was not an adrenal lesion. Now, when I look at adrenal masses, things I think about: clinical history and presentation. Is the patient Addisonian? Is the patient Cushing's? Is the patient hypertensive? Hypertensive patients, you're thinking about pheo, right? Cushing's, you're thinking about adrenal cortical carcinoma. We look at adrenal size, again, above, under 4, but recognizing that pheos or adrenal cortical carcinomas can be under 4 or over 4. Is the lesion unilateral or bilateral? What's the attenuation? Is it fat density and then a myelolipoma? Is there calcification? And is the calcification dense around the periphery? Then it's an old hematoma. And what's the enhancement pattern? It's enhancing above 120 Hounsfield units with thinking pheochromocytoma. And I mentioned before, and I'll just remind you that again, you want to make certain that the patient doesn't have a functioning lesion. So Cushing's, Conn's, and Pheo's are 3 very nice examples. Now, the incidentaloma, I wrote a paper about that a long time ago, and I remember when I wrote it, or before I wrote it, I thought the person who gave me the paper to write was very nice. He was one of the senior people in endocrinology, but I thought he made up the term incidentaloma, but it's not a make-up term. It means a non-functioning adrenal lesion discovered on an imaging study, performed for indications exclusive of adrenal-related conditions. Management of incidental adrenal masses is challenging, as we said. Now, some articles made it fairly simple. This article by Song, 973 consecutive patients with an incidental adrenal lesion and no history of cancer. The lesion was never malignant. It was most typically an adenoma or a myelolipoma. In this next article, Corwin, there were no malignancies in 322 incidentally detected bilateral adrenal nodules, so in patients without cancer. So now we're saying with cancer, obviously it's a different scenario, but incidental unilateral or bilateral lesions under 4 centimeters in these 2 articles were typically benign, and no follow-up was, in fact, suggested to be necessary. Now, when we look at tumors and tumor size, and again, talking about 4 centimeters, we always worry above 4 cm that we're dealing with a malignancy or some other problematic tumor. But this article from the Mayo Clinic made the point. They had 705 patients with lesions 4 cm or more. And in this, when you look at the underlying diagnosis, adenomas made up 31%, Pheo's 22%, other benign adrenal lesions 16%, adrenal cortical carcinoma 13%, and other malignancies 18%. So at the end of the day, malignancies only made up 1/3 of those larger tumors. The majority were going to be benign. So again, we use size as an important criteria, but recognize size is not always going to be successful. In conclusion, approximately 1/3 of radiologic proven adenomas in our retrospective single institution study grew over time. So here is another important thing. Adrenal lesions will grow. Myelolipomas will grow. Adenomas will grow. Malignancies will grow. But benign lesions like adenomas typically grow at less than 3 millimeters a year, while malignant lesions grow greater than 5. So if you have a lesion and you have a couple of time points, if it's growing less than 3 millimeters, that's a very helpful finding that it's a benign lesion. Now, the other thing we talk about is the attenuation. Well, it's been shown that on a non-contrast scan, 4 centimeters and less, an adrenal lesion that measures 10 centimeters or 10 Hounsfield units or less is going to be benign. Okay? Using a threshold of 10 Hounsfield units on non-contrast scans, a diagnosis of benign lipid-rich adenoma could be made with 98% specificity. Now, of course, we often don't have scans that are non-contrast because most of the CTs we do are going to have contrast, be it arterial phase or venous phase. And then we talk about looking at washout values. Benign adrenal lesions which measure, let's say, 5 Hounsfield units can enhance to 60 or 70 Hounsfield units with contrast. So if you only have contrast scans, you will overcall the significance of lesions. So again, non-contrast, if you want to look at an adrenal lesion, look with non-contrast. But if you have contrast, then we need to think about washout values. We'll also learn that not every adrenal adenoma is under 10 Hounsfield units. Some may be 20 or 30, and you can't call them adenomas. But when you give contrast, you could look at the washout value. Adrenal adenomas, when they enhance, they will wash out by 15 minutes at more than 60%. So again, it's not always going to be non-contrast. And here's just a nice example. Non-contrast scan, 2 centimeter lesion, right adrenal. It's an adenoma. Water density 0, no problem. Another case. This was really a renal case, but you see an incidental left adrenal lesion, about 2.5 centimeters, 6 Hounsfield units. It's an adenoma. You would stop here if the question was adrenal adenoma or not. But here was a kidney study, and now you look at the arterial phase, and you could see that the attenuation is 67, and on venous phase 56. So if you only had the venous phase, which is at 60 to 70 seconds, you would say this is not an adenoma because it's 60 Hounsfield units approximately. And then if you look at that same case on delayed scans, it measured 18. So now you see what we have. We have, if we only had non-contrast, or we had non-contrast plus other phases, it's easy. 6 Hounsfield units, diagnosis is made. But what if you only had arterial and venous? You can overcall the presence of pathology unless you get delayed phase imaging and look at the washout. That indeed becomes very important, and you could do it as an absolute washout when you have the non-contrast or a relative washout when you don't. People have thought about waiting 10 minutes from injection to look at washout values, and sometimes it works, but your sensitivity and specificity is way down. You need to do 15 minutes. And here's a good example. You look at the adrenal, 24 Hounsfield units non-contrast. At 60 seconds, it's 56. And at 15 minutes, it went down to 28. Greater than 60% washout value. This is a fat, poor adrenal adenoma. Nice example. Now, we mentioned that 4 centimeters or less, non-contrast, washout values, we make it seem life is simple. But look at this case. This is a 10.5 centimeter right adrenal lesion. It's enhancing. I could have thought, well, a strange tumor like a hemangioma because of enhancement, but those are really rare. I could think of an ACC. I would worry about some malignant tumor. This was an adenoma. So again, adenomas are not always going to be easy to diagnose. This patient did have the lesion resected. We did not think it looked that aggressive, but the vascularity was concerning, the size was concerning, and it was removed. And Chung makes that point. It may be impossible to distinguish a large atypical adenoma from an ACC or other malignant mass because of overlapping features. Again, multidisciplinary conference would be helpful, but in that case, it helped us understand what we were thinking about, but the patient still needs surgery, and at the end of the day, surgery was done for a benign lesion. Okay? Very, very important. Now, I mentioned before about hormonal evaluation or endocrine consultation. In Europe, when you see an incidental adrenal lesion, they basically say everybody should have hormonal workup. We do it less in the States. We really focus more on size and washout values. But in lesions that are hypervascular, obviously you're thinking pheo, you're going to do an adrenal workup. In other lesions where it's indeterminate, you'll also be doing an adrenal workup. So with that, what about consistency? How do radiologists really use the rules we spoke about? Do people follow the rules or do they not? Well, let's think about that for a moment, and let's take a break and come back in a few minutes, and we'll start with that. See you soon. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.